of Maharashtra. He is working very, very closely with Govt of Maharashtra, healthcare leader. He is currently overseeing medical devices, advances, surgeries, marketing for the HDF, all these things. Then our third panelist is Harish Rijhwani. He is a healthcare data analytics specialist with 17 years of work experience in delivering value of clients through technology and business services. He is also one of our visiting faculty who teaches data analytics in healthcare management. And our moderator this time is Dr. Pramod Prabhakaran. He is from Imperial College, Health Partners, UK. He has a work experience with the Central and Northwest London National Health Services. He's also founded one startup company. And he again has a first-hand experience in fighting COVID in UK in a completely different environment. So I welcome you all and I hand over to Dr. Pramod to take this further.
Thank you very much, Prema. It's a pleasure to be here together with all colleagues and a fantastic panel. In terms of keeping the discussion flowing and targeting it to the questions that emerge, we have to keep a close eye on the chat. Today's topic, we will look at the applications of data in healthcare in general and what the emerging trends are in terms of both data sources, data analysis, data management, and the insights we get from that. And I think all of this has accelerated in the last few months, given what's been going on with the COVID pandemic. We have the pleasure of having people on the ground with experience in India, Mr. Pakrawala from Jamshid from Singapore, and some of the UK experience. So hopefully we can bring about a good interactive discussion.
Absolutely.
If I may go through the panel members in alphabetical order to keep it simple, and I might invite Ayush. Ayush, if you would mind giving us a bit more background about yourself, about your role, and what's been happening with your role in recent months. You've emailed and touched upon a number of, I think, very pertinent issues that the panel, rest of the panel would like to learn from, but more so for our candidates at Somaiya. Ayush, over to you.
Sure, sir. Thank you. So I've been working as a Chief Minister's Fellow with the Govt of Maharashtra. In mid-March, when the lockdown just started, we were raising CSR for medical equipment and supplies. And that is when we were also ramping up our efforts along with the BMC to contain Corona in the city. The biggest problem during that time and the project which I was working on was the bed and supplies management, which is basically making sure that we are able to track the live status of what the beds is and what are the kind of supplies which are available within the hospitals in terms of the N95 suits, N95 masks or the PPE kits, and then making those same things available to the hospitals within the least possible amount of time. Apart from that, the other thing which I had been working on was managing patient data which is coming in from the hospitals, because as the cases mushroomed, the biggest problem then became the fact that we had to keep a track of all the patients, as well as find trends and patterns as to where we were seeing emerging hotspots which required more attention, and then bring in requisite policy interventions along with that. So I mean, these are the 2-3 areas which I've been working on over the past 3 months with the BMC.
Excellent. Maybe if I go to Harish, if you want to give a brief view on your background, Harish, a little bit more about what's been going on in the last few months.
So in the past few months, right? So overall, I've been working in the healthcare IT space for quite a long time. Mm-hmm. And I was there in Sintel for 15 years, after which I was working with Hinduja Global Solutions. And now I'm with CTS Tech, which is a core healthcare IT firm. So in my experience, right, one of the most important aspects when you look at it, right, even though, and I work with a lot of US healthcare hospitals, right? I work with a lot of US healthcare customers. And when you look at it from that perspective, right, the main revenue of a hospital is from the outpatient, from the surgeries and everything. And in the current situation, right, every hospital or most of the hospitals, right, are focused on COVID. So their main revenue is gone. So they are very much dependent on all the other activities that come in, right? So that is something which is how do you really generate additional revenue for a general hospital, right? And which is where you see a lot of focus now. And even in UK, right, the UK government ran a hackathon, and the outcome was one of the teams which won, right, they had built a mobile application for the elderly, right? That's where you see a lot of governments now focusing on healthcare specific hackathons. Even in Canada, there was a hackathon specifically around what should we do with the virus, right? What else can we look at it? Uh, there are a lot of research papers which have been around. Uh, if you go to Kagel's website, right, there are 180,000 research papers which have been there published on the website. But what do you do with it, right? That's where you use data analytics. That's where you use NLP to extract specific information from those research papers. Because there's so much research done by everybody, right? It's manually impossible for us to really understand the data which is there, right? You want to make certain common nuances that in this country XYZ item was done, right? In other countries, somebody is following something. So what are the best practices you can look at? And obviously there are a lot of other examples in the pharma world also, right, where you're looking at, on the news, right, they talk about so many examples, right? I mean, suddenly on the news they're coming and say, why does it take so long for you to discover a new medicine, right? So people do not understand the nitty gritties of that. And it does take, if you look at the entire life cycle from a pharma perspective, right, it takes approximately 20 years to come with a new medicine. But there are certain aspects wherein you can definitely use data analytics to reduce that time frame. The only reason why people are focusing on this now, right, because everybody is affected. There were solutions there before also, but now there is a very strong focus in terms of what should we do with that. And recently on 5th July, right, the Indian government also launched a hackathon specific to drug discovery, which they're going to do for approximately three months span, in 3 phases. So that's something I just wanted to share.
Brilliant, brilliant. Thank you, Harish. We'll come back to both Ayush and Harish have raised a number of pertinent things around how you use data for surveillance, patient care, for clinical trials, for drug discovery. Jamshid, could you add something from a Singapore perspective and your own role within J&J?
Yeah, so I think I have been watching this a little bit on the sidelines. And the reason for that is my career has essentially been in medical devices. So I have really spent my career associated with technologies that are in the operating room. This has been an extremely challenging period for medical devices business globally. So surgeries would be divided into elective and the non-elective ones. Elective surgeries, maybe something like a hip or a knee implant, you have the luxury of maybe postponing it by a few months or maybe 6 months or 7 months. But for something like cancer surgery, it has been a very, very challenging period where surgeons don't really have the ability to do the caseloads that they used to. Patients' access to hospitals is also constrained. So I see some of this coming back a little bit, but overall medical devices is going through a very challenging period. Now, having said that, I think part of medical devices is also surgical robotics. And there's a lot of talk around how potentially surgical robotics may evolve in the future. And one of the advantages of robotics is, we spoke a little bit about telemedicine earlier. And there have been some early kind of cases where you had a surgeon sitting in one location operating on a patient in another location using surgical robotics and using the power of the virtual technology. That is something that's really being worked upon right now in terms of, can we really expand the application of this remote surgery concept? I wouldn't want to say that we're like a year or two away. I think we're a long way away from making it a reality. But I think it's really situations like this that is really forcing us to take a long, hard look in terms of potentially how we could expand this application. So that's my view on this. And I have to say, I have been a little kind of distant in terms of not really being involved, I would say, at the heart of the battle. But I have been making some very interesting notes in terms of how in some places, the leadership communication, especially from governments, has really kind of contributed towards the overall population being able to accept and respond to the challenge a little better. So yeah, maybe we can talk about that.
Yeah, absolutely. And there are good examples, global examples being cited in that respect, Singapore being, of course, one of them. And I'm sure we'll come back to that. If I may, I mean, the UK perspective slightly, I mean, UK, it has been a scramble over the last few months for a fairly well-resourced health system, the largest sort of unified integrated health system globally. It should have gone a lot smoother than it did. So there were delays early on, probably the policy around letting people getting infected, the herd immunity policy. So there were, whether Public Health England, which is responsible for pandemic preparedness, had done enough, whether their policies were right, whether the data they had was right. There are lots of questions, especially in the early parts of the response. And that scramble has since then led to a response which has tried to utilize not just the public sector capability, but a lot of entrepreneurship, the innovator community with artificial intelligence, data, stock management. Ayush, you mentioned about masks and PPE. We work with two organizations that have really ramped up and supported the government in terms of managing the demand, working with the Defense Ministry. So,
hospital തന്നെ അവര് ഈ hospital management post graduation.
Hello, sorry, I didn't hear that. Was there a question there or? Okay, we'll come back to that. I think it'd be useful to have the questions on the chat so we can pick it up from there. So please do use the chat function. So it has been a difficult early response. Staff have at all levels struggled with initially lack of PPE, the right PPE, and then knowing colleagues getting infected and a number of mortalities. But the data parts of the UK health and care system is coming together and it's accelerating. So prior to the pandemic, Health Data Research UK was set up with a number of hubs, centers across the country. And that was to unify all sorts of health data from hospitals, from clinical trials, from research data, also the emerging data from wearables and apps, all of that to unify that, and then to really use good data analytics to try and get insights from the data. And I think we'll touch more upon that. So maybe Ayush, if you don't mind elaborating a bit on the data sources, or maybe even a step back and just if you could help just say what types of data do we get in Maharashtra? What are you using, and how is that being? What's the sort of process around data being managed?
Sure. So I'll start with the first app, which is the bed and supplies management app. It is basically it's like a Google form where we have all hospitals logging in their data, daily data, in terms of how many beds are vacant, how many beds have ventilators, how many beds have oxygen supplies, how many beds are in the non-COVID ward, because as we focused all our attention towards a lot of COVID cases, a lot of non-COVID emergencies suffered a lot because of no clear communication to the hospitals. So, I mean, those kind of data sets is what we were trying to capture from the hospitals. And the essential thing here being is that we wanted this to be a daily log, preferably twice a day, to keep it as real time as possible. Now, and the major challenge which we were facing here was the fact that uh, one, we did not have any data entry operators in all of these places because the hospital staff is not trained to carry out such activities. And the other issue was, I mean, something as trivial as not having a proper internet connection in all of these hospitals, maybe them having internet access, but not internet access. So they were not able to access data, anything outside their servers. So, I mean, these kind of problems was what we were facing initially. But yeah, so in terms of hospital data, this is one type of data which we were capturing. One was beds and the other
Okay.
was supplies to help the hospitals with their operations.
Yeah.
Uh, and with the patient data, what we've been trying is something which has been defined by the ICMR. It is something called as a patient line list, which basically captures the name, age, comorbidities, any, like, where is the patient currently admitted,
Mhm.
uh, what have been their testing dates and the corresponding results. And this again has to be done on a daily basis, where we set off a cutoff time to be able to capture how many discharges, how many deaths,
പിന്നെ
how
ഈ
many
പഴയ
transfers are
സാധനത്തിൽ
taking place.
പൊല്യൂഷൻ എന്ന് പറഞ്ഞിട്ടൊരു സാധനം ഉണ്ട്. അതുകൊണ്ടാണ് ഇത് BS6 ആണ്.
Sorry,
നമ്മുടെ
Ayush, I think
BS4
somebody
ആണ്.
needs to be on mute there.
Yeah,
Please continue, Ayush.
yeah. Uh, and so, yeah, so I was talking about the patient data. So that is something
Mm.
which we've been capturing every day, and using this data, we parallelly have a team of AI researchers. But I think that is something we'll go on to later
Okay.
in the
Okay.
discussion. But this is the kind of data collection activity which has been going around.
And Ayush, so does that include the government hospitals, the private hospitals across the state? Ayush, does that include the private and the public hospitals across the state? Ayush, you're on mute. Ayush, you're on mute.
Hello.
Oh, yes, now I can hear you.
Yeah, I
Okay.
was unable to unmute myself. Yeah.
Yeah.
Yeah, so it includes all kinds of hospitals, which is private, government, semi-government, everything. And the jurisdiction is not the state, though. It is according to municipal corporations.
Okay.
So like that kind of decentralization has come in. So all districts are having their own separate data sets, while for Mumbai and Thane regions, we have the respective municipal corporations which have been taking care of such cases.
Would you be able to give a sense of the extent of this data? I know, we always talk about data. Sometimes people, we don't realize the enormity of a task like this or the data like this. Are you able to shed some sort of give an estimate of?
So I could help you with the number of facilities which we have onboarded. Like currently, we've been tracking some 120 facilities.
Mm-hmm.
So let me just go back a step further.
Yeah.
We have three distinctions of hospitals. One is the CCCs. Then there is the DCHCs, and then there is a DCH. CCC stands for the COVID Care Centers, which is basically for patients which is basically like an institutional quarantine facility. Say for somebody who is not able to, quarantine themselves, they do not have access to maybe private toilets or something. So the government is using those kind of facilities to keep people there. Then there comes the DCHCs, which is for patients showing mild symptoms and who might require a bit of a medical care. And then there are the DCHs, which is a dedicated COVID hospitals. Dedicated COVID hospitals are the ones which are having the ICUs, the
Yeah.
oxygen beds, ventilators, and stuff like that. So in the DCH, currently we are managing around 100 to 120 facilities on a daily basis. Parallel to that, I mean, I'm not very closely involved with what the CCCs and the CCC DCHCs. The CCC has two differentiations also based on the severity of the systems. So CCC1 and CCC2 are also there.
Okay.
But yeah, I mean, in terms of the number of facilities, there is 100 and 120 between the top two tier of the facilities.
Brilliant. So clearly a huge set of data. One question from Ameya Nirlekar, and I suppose that probably is the questions. If you can see Ayush also, it's about why can't the state come up with an app or a website which hospitals need to register as part of a compliance policies, and then it gets integrated into the hospital management software, database software.
So yeah, very good question. I mean, this is like naturally one of the first question that comes to somebody's mind who'd be talking about managing a system like that. But I mean, some of the problems which I can think of right now, I mean, which are preventing us. One, so while this system has been loosely implemented, where we see that a directive by the BMC to get all the hospitals enrolled under a system has already been put up, but one, making sure that they are complying with all of these is a task. To ensure compliance, where I mean, it is not a technological solution but a human solution, where we've put in more a few officers to monitor what kind of activities I mean, why are these hospitals not complying, and to make sure that uh, they are presenting their data in a very transparent manner. So we've put in a few officers there who are constantly engaging with all of these hospitals to make sure that that is done. But in maybe an app or a website as a final product is something which we haven't reached right now, because I mean, we've been trying for that though, like, very honestly. But the biggest challenge there comes in the fact that while you have so many data, say for example you have those 120 facilities which you want to transfer to an app the next day, but the problem then becomes that you always have to retrain your people to be able to use those apps in a single day. The larger problem here being is that this has to be within a 24-hour cycle itself, because the other day the data will get refreshed, and then I mean, you might be just losing out on data and causing more chaos instead of solving a lot of problems. So I mean, that is the other kind of challenge in implementing something like this. But this is something which is definitely, we are trying to slowly move towards. Like, we've got a few companies who are coming up with their own HMIS systems, and we are trying to use their APIs to centralize all the data and then be able to monitor that. So,
and I think that's in a nutshell, there are so many challenges around data capture, where there may not be uniform systems across different hospitals or reporting mechanisms. So this has really triggered a need for these reporting mechanisms. And my comment back to Ameya would be that these are really areas of opportunity. I think anything to do with healthcare data, health and wellness data more broadly, becomes huge opportunities for that's the trend of the future, and these are opportunities for all of us sitting here to try and shape that. Harish, Jamshed, do you want to come into that sort of hospital data management, or
So I'd like to add a point here, right? So I'd like to add a point over here, right? When I look at how other countries have been trying to do this, right? In 2009, when Obama came in to the US, right, to the US government, he came out with a plan that we need to first capture data. So like Ayush mentioned, right, the biggest challenge is to change the mindset of a person, right? You need to use that data. And there are multiple ways of doing that also. So it's like, if you look at your own mobile phone, right, you'll find so many apps. You probably use only 3 or 4 of them. You have probably 70 apps on that, but you're only using 3 or 4 of them, because that's something, it's like an incentive for you. And when Obama came in, right, he came up with the concept of meaningfully using that data. So he called it 3 phases of meaningful use of data, right? So first phase, you want to implement an EMR system in each of those hospitals. And it's not like just you implementing it, you also have to use it, because once you capture that data, right, only then will you be able to share that data with anybody else. So the way Ayush mentioned it, they have a Google form where people are entering that information. Ideally, it should be automatic, that once it's there in your system, right, it gets sent to BMC and they're able to monitor that real time. As of now, what is depending on is again a person. And there too, right, when you're capturing information of a patient, right, there are organizations like there are organizations like next gen, right? They have a pen wherein the doctor can actually just write on a paper and that information gets captured in the EMR system. They just have a different kind of a paper. So there are a lot of organizations like that which have these solutions. There are many solutions out there. It's more in terms of, having a global plan or a countrywide plan. That okay, I know there is a plan in place for India, but there has to also be some kind of incentive for hospitals to really implement this, right? So that in that plan, right, that thought process, even all other countries have been doing that. So the only thing which I saw from the perspective of Obama, that he was giving an incentive that if you implement, you're going to get a certain amount of money, provided you use that EMR system properly. I just want to mention that one.
And the EMR, again, we often have questions about data quality, data completeness, and it takes years of use of EMR to address both those issues, because the output often depends on the input. Jamshed, your reflections?
Yeah, so this is a, I would say, big hairy animal to tackle, because I think especially when you talk India and the kind of volumes, it's humongous. Now, I think this is a good conversation on incentive. My view on this is, which are the countries that already have some semblance of success in place? These are the countries that have I would say, a national health insurance database in place, which means even before COVID, if a patient wanted to get access to healthcare, he had to be in a database. If he or she was not in a database, even admission to a hospital was out of the question, right? So I think when you have a fundamental situation like that, it automatically addresses the issue of incentive, or it automatically addresses the issue of not doing it just because we are in a coronavirus crisis. Now that brings us to another challenge. When you take the healthcare system of so many countries around the world, where payment is out of pocket, automatically this argument gets diluted. Out-of-pocket payment in India, by various estimates, varies from 60% to 80%, again, depending on the area, demographics, epidemiology, whatever. And so the question is, if the access to healthcare is not going to be determined by a central authority, then the challenge is, what's the incentive to do it? Is it going to be just collecting the data for the sake of collecting the data, right? So take, for example, I think areas where India has done this wonderfully well, which is like, let's say, maybe the PAN number. And I know a lot of conversation has happened on Aadhaar, but look at the PAN number. Almost everybody in this room has a PAN number, and you need your PAN number to file your income tax returns. And similarly, the government has all the financial data on record for the past few years. So I think this is a good parallel that we can draw in terms of what are you going to do with this database? And I think this conversation shouldn't be restricted to just COVID or coronavirus alone, because you don't know what healthcare challenge we're going to face 5 years, 10 years down the line. So this is about the fundamental way in which, I wouldn't use the term socialistic healthcare model works, but about, let's say, maybe a better way to describe it is how the public healthcare model works. And that's never going to be a situation in India where healthcare will be delivered in the public sector. So enrolling the private and the public into a sort of system where there is some sort of electronic medical record, and regardless of whether the patient then has to go back to the insurance company to claim the payment or make a self out-of-pocket payment, then the system starts to make sense.
Absolutely.
Right.
Absolutely.
And there's going to be a cost associated to it. So I think Ayush brings up a great point in terms of the healthcare providers not being trained to do it. It's going to add a cost to the system. So how do you then account for it within the already burgeoning challenges of healthcare system costs?
And I suppose it's about really being able to communicate the value of data. What is the point of data? You can collect loads of data, but data should lead to insights and actions, which then really communicate the value in terms of improvement in health outcomes and preventive health outcomes. I'll give 2 examples from a few years ago on data. So this is pre-COVID. And the UK primary care data set in the last 7 years has become much more uniform. And there are two basic electronic health systems, EHR, EMR systems that's used. And it's very comprehensive. I think they're very good data sets. And it's used partly for contracting purposes for primary care for GPs. But we had a project where we looked at atrial fibrillation. So atrial fibrillation is irregular heart rhythm, which increases the risk of strokes. And we had an estimate of how many people in Northwest London, 2.3 million population, would likely have atrial fibrillation based on some of the research data. So we had a prevalence data. So we expected so many people to have atrial fibrillation. But then when we looked at data on medication prescribed, the number there was a significant mismatch. So we were clearly underdiagnosing atrial fibrillation. What we then looked at was all the risk factors for atrial fibrillation. And you could almost remotely analyze electronic health records. To an extent, you could come up with a short list of patients per GP that they could review and confirm whether they had atrial fibrillation through ECG or not. So that was one use of data in the UK. We have done similarly to look at frailty. So there are 36 indicators for something called e-frailty index. And you could again run these remotely. So there was no real clinical time associated with it down the line or an additional person doing it. A lot of it could be generating reports, which then helps you focus down and actually saves you time. So I think there's the value in terms of time used. About 2 years ago, I did a 1-year collaborative project in Shanghai, where we looked at the 20 million records of the residents in Shanghai, of the registered residents in Shanghai, looking at healthcare utilization cost. And we were able to create almost a lifetime expense simulator to look at where in the life stages would the maximum cost of healthcare be. But it was big data. It was huge data sets, and we had to go down more machine learning and algorithms. And I'm sure there'll be, maybe Harish can touch a bit upon what that all means, and we can share some thoughts on that. But there were data applications being done well before this. And I think COVID in a way has accelerated and highlighted the need for there to be a patient level health record, and secondly, a hospital level system which can push information, and reporting should not become manually onerous, that it could be automatically generated, point Harish was making. And probably those are the real opportunities, because wherever I go in the world, there's huge disparity between how systems run. And there are some good models in some places and some very strong models in other places. And it's about that sort of integrating those bits of learning and looking at what's the right model for wherever you are. And I think those are the opportunities. Harish, do you want to touch upon how data gets analyzed? How do you manage data? What do these things mean from a data science point of view?
So I'd like to add one point, right? When you talk about, before I get into the data analytics, right, the personal health record we talked about, right? When I look at it, right, there has to also be a mindset change from a patient perspective, because it's not looking at your bank balance on the first of the month, right? That you're happy to look at that amount, whatever that amount might be, right? It's as easy
or
as
not.
yeah, or not, whatever that might be, right? So it's like that is there on the board, right? It's not going to, you wouldn't want to share what was your blood sugar level today or what was your blood pressure today, right? It's very sensitive to you, and people avoid that because it's a mindset. That is the way it is. So even Google Health that had a personal health record, Microsoft Health Vault built a personal health record, right? PHR, which is open for everybody, but they didn't find a lot of takers for that. So it's again a mindset change. It might take a longer time, and which is where medical devices, you have these smart watches, right? They monitor that information, they monitor that data. That is where you see the young generation getting into using those. So you'll get some level of information from there. But again, there, right, you need a FDA certified device. Otherwise, you might not be really monitoring yourself properly. So here, right, when you're talking about huge volumes of data, right, one way is how do I capture that information or how do I share that information. And recently, in few days back, right, on the HL7 chapter of India, there was a demonstration done by a group of people where they showcased that using Fire, which is one of the latest standards of transmitting data, right? Using Fire, they were able to connect and show the use case for teleconsultation. So anybody could connect with any physician for that matter, right? So one is obviously when you want to capture data, right, you need to have an EMR system in place from where you want to extract that information. And there are different standards. There are terminology standards, there are technology standards, right? In terms of your terminology standards, right, you have SNOMED. I know in India, in some time, they're going to using SNOMED and LOINC, all these codes which are there, right? People understand it. The computer system will probably understand that better than a normal person, because the computer does not understand free text. The computer understands codes. That is where you have that level of information. Second, then you have EDI and Fire and HL7 wherein you can extract that information. So once you have all of that information, right, that is where you'll be able to analyze that data. And I'll give you a very simple example from a pharma perspective, right? There is a company called Clinithink. I was working with them in my previous organization. We were trying to work a partnership with them, and they are UK based. What they do, right? They have a tool called Clicks Enrich, and they use all of that information from the patient notes. Okay, they're using the physician notes which have been written, obviously in electronic format, and they identify patients for clinical trials. It takes a huge amount of time to register a patient for a clinical trial. All right, in terms of it might even take you 9 months to 1 year, right? Because you have to look at tons of data. Somebody has to sit and read that paper, read the medical records of that patient and identify the person for that. This tool does it in less than 15 hours. They were able to find out approximately 8,000, and it's there on their website, right? It's there in their case study also. They were able to identify more than 8,000 odd patients for, so that somebody could go and get them enrolled for a clinical trial. Okay? So that is the power of how you can really use data. And the other example, which is very relevant today, right? I talked about the thought in terms of drug discovery, right? What is important in drug discovery is, and I'm not a pharma person, but yes, in terms of how things really work, is you need to know how that molecule is going to react, right? In terms of the solubility and all the other factors. So there are algorithms which have been written around that, which help a person to, reduce that time frame to shortlist those molecules. And you can go to AI Cures MIT, right? If you look at that, right, there are certain challenges which are out there. They have written certain algorithms specifically around pharma, and this is a real need in the current situation, and not necessarily just for COVID, but that algorithm can be leveraged for any new medication which has to be there in the market, right? Those are a couple of examples which I wanted to talk about, and the volume of data is pretty huge.
Yeah.
The final example which I just wanted to touch base was again in the pharma world, right? You want to find out the size of the protein molecule, right? The virus kind of, and there is a challenge which happens in terms of uh, protein binding, and you don't know the size of the what do you say the virus. It changes because of, and the COVID virus, right, it's much bigger as compared to the normal viruses which are there, which is why you have a much bigger challenge. And Google DeepMind came up with the thought of, they have put together an algorithm where they are able to leverage that algorithm to predict or find out the molecular, the structure of that particular virus. So there, right, we tried to download the data. It's approximately 50 GB. So even if I want to run it on my machine, it's not possible. So you require very high computing power to do some of these tasks. So the data out there, if you're going to capture it, is going to be huge. And there are a lot of things you can do from here, from clinical decision support making to a lot of things, right?
Yeah, absolutely. Thank you. Thank you very much, Harish. Very interesting observations. And you sort of almost through the examples mapped the data capture element, the data analysis element. Obviously, a lot goes into maintaining the data. You have to keep the quality, the data warehouses all of that. And you touched upon the analysis of data, the use of algorithms, AI, machine learning to try and make sense of it. And I think a big challenge back as a clinician I've had is that there's been so much data being filled in. It all seemed to be one way. You filled in the patient records, you filled in the Excel spreadsheets, some years back. All of that went in. What came back was not very meaningful. It came back sometimes huge spreadsheets asking you to, red flagged items for performance and completeness issue, but nothing really positive or meaningful that applied to my clinical practice. Right. But I see that's changing now. I see that's changing, and that's partly the sort of whole communicating data part of it, which I think is as important as everything else.
Yes, I just like to add one point, right? A technical person, right, many a time does not understand the business, the business aspect, the business need, which is where you will find a gap in terms of how do I convert a technology solution in terms of a business solution, right? If I give you a very basic example, right? If you have a CD in front of you versus the chocolate, right, which is wrapped very nicely, you'll probably choose the chocolate versus the CD, because the technical solution, right, has to be packaged in a way that somebody can understand it very easily. That is one of the biggest gaps. You have the solution, you have the ideas, but how do I really sell it to somebody who's going to buy it for you? Right? You have something in your mind, right? And the other person also has a solution for it, but he's not able to communicate that to you. That's a big gap, which is probably we need to fill.
Yeah. Jamshed, any reflections, thoughts?
Yeah, there's some thoughts I want to just put out there to the panel. I think we all agree that it's a humongous task to first and foremost get the data, then how exactly will we process it, again, how accurate is it going to be, and then again, how precisely will this data be used going forward. There is a fundamental point here, which also needs to be taken into consideration, is the comfort level of people to share this data. And I think Harish, you touched upon this. I'll give you an example. Let's say where I live in Singapore, I have a national identification number, a single national identification number. With that number, the government can track my entry and exit. The government can track my financial tax returns. The government can also track potentially how much money I have in the country, how much I have been sending out of the country. So they can track a lot of stuff based on one identification number. Now the question is, potentially this could also be used to include my health data, which doesn't exist today, but it can be used. So my question is, in India, we've been through a lot of, I would say, discussion in the past 2 years on people not wanting to maybe link their Aadhaar with the PAN, or not wanting to quote their Aadhaar, and there are beliefs, there are misgivings. So my concern is, how keen are people going to be to divulge this data? For some people, healthcare data may be not an issue, but for some people, it may be a very personal kind of topic. So I think an aspect that needs to be looked at is the ability of people to volunteer that data and their comfort level. And then the other concern I have is, if that data needs to be shared cross-border for some purpose of analysis. I'll tell you why, because as far as some of the artificial intelligence work that we are doing, as far as surgery and robotics is concerned, there is an emerging conversation around the fact that the data may have to be shared cross-border. And that's where governments are putting their fences up. They're saying, no, you need to have the server within the country. We're not going to be allowing you to take the data out of this country. So I think it also brings up those questions in terms of, the second one is, what exactly will we do with the data? And that needs to be defined.
Yeah, absolutely. Absolutely. I think it really leads us to, there were two other big topics, Jamshed. One, as you alluded to, is really around how comfortable do people feel with data being used? And that links into what is the ethics around data use. Is the data, what's the security of the data, and how transparent should be the data? And there are different models. We've had loads of time and gray hair spent on data governance, agreeing data sharing arrangements. I was going to just put on a slide which shows some of the illustration here, but maybe Ayush, while you could give us a view on where it is from a government perspective in Maharashtra through your work. And I'll load a slide which is just showing some data use here in terms of privacy, etc. in the UK.
Sure. Yeah. So in terms of the ability of people to be volunteering this data, I feel that the Indian population might be quite receptive of such a solution because I mean, our priorities are much different from other societies. I mean, if we're not, I mean, if in return for that kind of a data, we are getting, better healthcare services, I think that is something which people will be up for it. Though cross-border sharing is something which I feel is, I mean, our governments are too far away from, implementing something like that. I mean, and far too protectionist right now, especially with, I mean, with the kind of, you know uh, the agendas the governments are running. I feel, I mean, cross-border sharing is something which we're quite far away from, but the ability of these people to be giving, be open to sharing their data is something I'm quite confident in, is that people would be comfortable with.
Okay. That's very good, because there's we've had a number of challenges in people wanting to share data. I suppose that I've just put an illustration on the PowerPoint, which is from pre-COVID, and it's a program. I think one of the most comprehensive data sets is this whole systems integrated care data set. And I just wanted to draw your attention to the bottom of the slide, which to the left is the identifiable data set, which is really at a caregiver level, both from primary care, community, and hospital care. The data then obviously gets de-identified and is used for, so this is Northwest London, 2.3 million population. And the data integration happens at a level which includes all the hospitals, all primary care, mental health care, social care, and some of the community voluntary sector information, mainly related to disability and frailty. So one of the most comprehensive, good data sets, I would say, in the UK. At a clinical level, the case finding tools would help GPs drill down into their patient cohort. So I mentioned atrial fibrillation and frailty. So you could really look at the parameters, run analytical studies, and hone down to the GP. And also link that with the secondary care. So the hospital, primary care can link together. The patient can view their own summary. They have access to the same records. So that's at a clinical care. The left side of the slide illustrates how there could be integrated care. And that's the point of it, to try and move care into the community, closer to home. And to the right is really where you are trying to look at population health management and research. ACP stand for Accountable Care Partnerships. That's really bringing together different parts of the health system into one accountable organization. And that is really an enabler for that. But research, and now it's as part of this, there's a clinical trials register called Discover Now. Again, as Harish, you were saying, if the front end work is done, it really makes it easier down the line. And it gives you really good insights. So now we've developed a lot of population health management tools, which can then be modeled, and you can say, you can look at interventions and what the outcomes would be at a population health level. So yeah, so you know, I think there are opportunities globally to try and integrate data sets and use that both for a individual care level, but also from a health system in a population health management level. I wanted to ask how things are progressing in India in terms of surveillance, this surveillance and contact tracing, because that again, links into how comfortable are people divulging data on where they've been, who they've met. Do we have good systems, and what are the, and then maybe we could touch upon what are the big opportunities in this space, data. And maybe then Ayush, you can lead into communication. What's the state doing in terms of communication?
Sure. So, I mean, in terms of tracking and tracing, like the two major apps which are being employed in Maharashtra, one is Arogya Switi, which is being covered nationally, and I mean, it has received its fair share of uproar against it, the privacy concerns it has raised. Apart from that, something which is different in Maharashtra is something called as Mahakavach, which we've implemented only for quarantine patients. Say for example, if the government wants to track these people, so initially the problem was that people were not staying in their quarantine facilities. If they'd been asked to isolate in their homes, they were not following those instructions, and that is something which we wanted to counter, which is why we came up with the Mahakavach app. And that is quite similar to the Arogya Setu, and it has been developed uh, along the MIT Safe Paths kit, which has been worked on by Professor Ramesh Raskar. Uh, so the idea is that basically, like, we can track at any given point of time whether a person is going out of the defined zone which they've been asked to be in. I mean, and if there is any violation, then the police or the local district authorities are notified of the same, to make sure that such people are not roaming around irresponsibly, you know and spreading more cases. So I mean those are the two major technological interventions in terms of tracking people. And I mean, it has worked fairly well. I mean, so I know for a fact that Nashik Municipal Corporation in Maharashtra had uh, a very detailed dashboard as to how many patients, how many, I should say, people were quarantined in their facilities and where they were at whatever points of time. It had things like random selfie attendance, because people in India, I mean, if you ask them to install an app, so they'll just leave the phone at home and then go out wherever they want to. So you need to put in checks like that. So I mean, that is something which was quite unique in this product. So yeah, I mean, like, that has been the two major things which we've been trying.
Just tell me a little bit more about the random selfie thing.
Yeah.
How does
So
that work, Ayush?
yes, yeah. So the idea is that every day at any random point of time, you will be asked to click a selfie. I mean, you will get a notification of on your phone through that app, and you will be asked to click a selfie. Now that selfie, I mean, it will be analyzed by the system in the background to check whether it's the same person or not. And if it is not, I mean, if the photo is not matching, if the lighting conditions are not satisfactory, I mean, if the system gives a yes or a no whether this photo is satisfactory or not, then the police or the district officials, they call the guy up. I mean, if not, then you go to the place and you make sure that they are staying in their respective confined zone. So I mean, so that was the basic idea. And also, I mean, if you uninstall the app, we also get to know that. So I mean, basically there's no running away from us once we have that app on your phone. So no concern for privacy there.
And is that mandatory, the app?
Yes. So basis, I mean, initially it was. Now I feel, I mean, it is not being imposed as stringently as it was being implemented earlier. But yeah, initially it was.
Okay. Thank you, thank you. And Jamshid, how's the surveillance working? You know, what are the sort of mechanics behind that in Singapore?
So it's pretty similar. So just as the Ayogya Setu app in India, which by the way, I'm not familiar with, I guess I'll have to download it at some time. We have what is called as a government track and trace app. I found this example of taking a selfie pretty interesting because I don't think we have anything like that here, but we have the track and trace app. Now, the track and trace app basically works with Bluetooth near field communication. So for example, I need to keep that on constantly, even at home. So for example, if I have any visitors coming home, then automatically the app is constantly logging who all I've been in close proximity with. None of the data is visible to me. It's obviously data that's being collected somewhere, analyzed. But what the government is trying to do is, assuming if a citizen then gets affected with COVID, then they are able to go back and track that data, take a download, and see who all this person came in contact with. So I think this is a pretty kind of similar system. But where I think Singapore has really taken it much, much ahead, and I want to be respectful. I mean, the challenges of doing something in a population of 5 million versus, you know, Mumbai itself, which is 4 times that amount, is significantly different, is I cannot go anywhere without registering myself when I enter that facility. If I go to a friend's apartment, I have to scan a QR code and check into his apartment, and I have to scan the QR code and check out of the apartment. So someone somewhere knows what time I entered the apartment of my friend and what time I sort of exited. And it's not the apartment, it's for the whole basic apartment block. If I need to go to a mall, I cannot enter the mall because besides the guy mandatorily taking my temperature, I also need to scan the QR code and check into the mall. And then of course I can roam around within the mall wherever I want. And then when I exit the mall, I have to once again check out. So, you know, someone somewhere knows exactly how long I've been there. So I think similar systems, but I think they've taken it to a kind of a next level in terms of keeping a tab on who goes where, because coming down to the most important thing, which I think they've done a fantastic job in Dharavi as I read, it's all about contact tracing. So what I essentially described was just another method of contact tracing, which I think they've taken to the next level here.
Brilliant, brilliant. I mean, Harish, any thoughts on that? Your observations?
So, especially in contact tracing, right? Practically, if you look at it, right, telecom vendor can very easily find out, you know, which person has been near which other person. But there are a lot of privacy challenges in that. But China had built a similar app in the beginning, wherein they were able to easily find out or trace those contacts using the help of the telecom vendor. But I don't think that would be very acceptable in most environments, right? That is where I do agree with the mechanisms we're currently using, right? Otherwise, it's not so easy to trace which person has, you know, met which other person. So you need those interfaces like a QR code or the Arogya Setu app, wherein you know that this person is coming from a red zone or a green zone. Where is that person coming from?
I think, you know, India, in various parts of India, Dharavi, you know, human interface in terms of contact tracing, the use of ASHA workers in up and down the country has been very effective. But there are, I think, opportunities for innovators and, you know, to work with the health system, with the governments, to try and look at where the gaps are and make it easier and more effective for people. While all of this is going on, I have a question here from Ravindra Baliga, who says, you know, we're all focused on COVID. What's happening to malaria, pneumonia, cancer, etc.? At a state level, how much focus is there on that, Ayush?
So definitely it has been affected to an extent. I mean, the kind of, say for example, the team of doctors which has been doing the analysis for the COVID cases was initially involved in the analysis for the TB program in the city. So I mean, but I mean, slowly that has started to also, I mean, that problem is also started to being resolved, because you also, I mean, we've defined all the processes for COVID right now. I mean, we're in a place that uh, you know a lot of our processes have become automated. Everybody knows what their job is in the whole cycle, and this is when, I mean, we're starting to divert our attention towards these illnesses like malaria, pneumonia. I mean, with the number of cases, I mean, at least in Mumbai, I can say that a lot of non-COVID beds have also started to be released for critical cancer care patients. So I mean, that is something, a positive trend which we're moving towards.
Yeah.
While it was not there for the initial 2.5 months, like when we were at the peak of fighting this.
Yeah, and it's similar in the UK also. I think there was a 63% drop in emergency department attendance for all sorts of conditions. So heart attacks, strokes, people would have access to emergency. So they're not going there. So we are identifying people in more serious conditions and later down the pathway. Cancer is a big challenge. We are slowly beginning to open up cancer services, but the diagnostics, the appointments that are needed, it's expected to take about 2 years to really cover for all of these. So it's going to be a huge drain on services. Just checking, no further questions there. So could we perhaps look at what are some of the best practices, some of the stories that we would like to learn from, and perhaps Jamshid, you mentioned about Singapore, which is, I think, one of the it's a very impressive system in Singapore, and it has been agile and it's acted well. And we hear about Dharavi, where we expect some of the general social distancing measures to be hugely challenging to implement, but we have almost people chasing the virus rather than waiting for the virus to slow down in the community. So there are good examples, and maybe Ayush, you may have other examples. Harish, you may have some examples we could touch upon. I also have one or two from the UK that I can touch upon if needed.
So I think what I can share here, Pramod, is a slightly different example, which is really the Taiwan example. And I think Taiwan has also been held up in terms of a kind of a best practice for a couple of reasons, not just in terms of how they've managed to combat the virus, but also in terms of the fact that Taiwan was one of the countries with a greater, I wouldn't say proximity, but a greater exchange of the population with mainland China. Statistically, I think out of a total population of maybe about 23 million Taiwanese citizens, close to 1 million citizens live and work in China. So if you construct the scenario around the time of Chinese New Year, when really this was evolving, you had a lot of people in Taiwan who were also potentially kind of coming back for the annual holidays. And Taiwan is one of the countries that really has this comprehensive database for the national health insurance. And we can read about this in secondary sources also. But what I found very interesting was they were able to map their immigration system to the National Health Insurance Registry. And so therefore, when people were coming into Taiwan, they were basically able to identify travelers based on their previous pre-existing conditions as a first kind of check. And then even before these people really got off the plane, there could be an identification of those who could be at higher risk versus lower risk. The second thing they did was, before people even got off the plane, was they took a look at the travel history. So before people got on the flight, they had to sort of enter areas that they had been to. And that really led to a second section of people returning who they were able to identify as high risk and low risk. So now you suddenly take the example of somebody who, because of his pre-existing conditions from the National Health Database, is anyway identified as a high-risk person, maybe because of some comorbidities. And then you layer in the fact that he has visited a level 3 kind of city, which means he's really at the highest level of risk. And so when that Taiwanese citizen returns to Taiwan, he's really observed a little more closely in terms of his quarantining, his behavior, and plus that person maybe goes through some additional screening also. And I think when we are talking about data analytics, I thought this was an excellent and creative way to map two existing systems together. Of course, a lot of our discussion today has been in terms of how we really set up the system and how we go about it. But I think this is a great insight into the possibilities of what one can do when one has analytics, and how one can creatively sort of overlap and do a lot of data mining to determine what can be your course of action.
Absolutely, absolutely. That's really well put. And I might bring in Harish here to give a sense, and we'll come back to you, Harish. But Harish, where is data moving towards, globally in India, also? Where is data? I mean, we have multiple data sources coming. So what's your sense of, in 10 years' time, where would we be with data?
So in 10 years' time, right? So if I talk about the aspect of, which is a growing trend right nowadays in terms of telehealth, teleconsultation, right? Teleconsultation cannot just be your talking with a physician on the phone or just chatting with him, right? It also has to be with capturing data from your side. Ideally what should happen in telemedicine is, right, your data, the patient themselves should also have specific medical devices using which they can capture that information. I think there is also going to be a trend where, if the situation is going to continue for a long time, right, everybody would want to monitor themselves, because that's going to be a need. And individually, people will have as simple things like a pulse oximeter, or for that matter, right, a BP monitor or sugar monitor. People might start monitoring that data. So the data might increase from individual patients. That data source might be there. It's an additional data source, though only the elderly and people who are being monitored, right? So my mom, she has to use a BiPAP, and so we check her pulse oximeter every day. I mean, the pulse oxygen level, SpO2 level, every day we check that. So that's something data which is captured. And there is a device which we use of Nonin that is able to, through Bluetooth, right, it is able to transmit that data on my mobile application. So I can share that information if required with the physician, real time. There's a solution by HealthCon wherein you can, so they have one device itself using which they can capture information like your SpO2, your ECG. That same device does the same thing. It does 7 different functions. It can also record the sound of your lungs, right? Because that is where the doctor listens to the sound and tells whether there is a congestion in the lungs or not, right? Or if there is a heart lung problem, whatever that is, right? Because as a normal person, I will not understand that. So these devices people might start buying for themselves. That is where you might get that information, and that is really where telemedicine or something like that will really be more successful, rather than just a chat window with the physician. I think that's where we might have more data coming in.
And if you add to that the sort of wellness data, health activity tracker data, then you have suddenly at an individual patient level, you'll have more data than some hospitals keep now. Right?
I'll give you a very simple example, right? When if I use a debit card or a credit card, right? If I use that debit card or a credit card for 3 or 4 times in a span of 10 minutes, right? Now, most of the times you'll get a call from the bank stating, have you used this, in the span? That's like a spike. And imagine from a wellness perspective, you are capturing that data and doctor is monitoring that. Okay, in the morning you had a pizza, afternoon you had some other snacks, right? And you also captured your blood sugar level in the morning. Just relate that example, and suddenly in the night you'll get a call from the doctor, you cannot eat this in the night, right? Or you have to monitor your blood sugar level. That's the level of interaction or interoperability which could happen if people start capturing that data in that fashion.
And I think, there is a sense globally that you have to move healthcare towards that. So people self-manage, because the health systems won't be able to afford the needs, because we're all living older and with multiple morbidities. So we need to manage that, and governments are supportive of people, and a big part of that is the data agenda. And I wonder what are the opportunities really for people to work in that space, in India, and internationally, but in India. And I mean, if there were people who came up with projects saying we want to do more hackathons and look at more solutions to meet some of these big challenges, are there funds, grants? What's the sort of facilitation at a state level?
I mean, yeah, so very interesting question. So I do not normally work with the BMC. My original deputation is with the Maharashtra State Innovation Society, which is responsible for getting in more innovation, technology, and startups into various sectors in the state. And in fact, like, we are going to launch the startup policy for the state in the next month, which has healthcare as one of its main agendas. Whereas, I mean, Mr. Harish was mentioning, the hackathons, in UK, where the app for the elderly won that. So, I mean, we are trying to promote more kind of those hackathons. And I mean, over the next year, you will be seeing, I mean, those kind of hackathons happening across colleges and research centers in collaboration with medical research institutes across the state. So, I mean, that is something very encouraging, which we are trying to move towards. And as we are talking, there are also technological interventions which are being being tested and deployed across hospitals, in terms of, like, how he mentioned that you have a specific kind of paper or a tablet where you're recording the patient vitals, and then they are directly being fed to the EHR system, EMR system, whatever you call it. So those kind of interventions are something which we're moving towards. Plus, we also have this thing called Maharashtra Startup Week, where we invite solutions, from startups across all fields, and we provide them an opportunity to work with the government. Like, we give them a work order to implement their solutions. So, with healthcare as a focus, we'll be seeing more of these solutions coming forward. A last point to add to that, yeah, just last one. See, like, a lot of our startups, say for example, I mean, we had a lot of startups working in different fields, but during the COVID times, they have pivoted their business models to be working towards healthcare in general. So I mean, that is something which signals to the point that we'll be seeing a lot of innovation in the coming times. I mean, as maybe it might be something which the startups have been forced to do, because I mean, there's no commerce involved anywhere else. But I mean, that is something we're surely going to see in the next few years.
Brilliant. If we can spend a few minutes, there's a few questions, really interesting questions coming up. But if you could spend a few minutes talking about the role of communication. We may have to pick it up on one of the other webinars because it might be a big topic, but there's so much news and fake news and disputes. Just one or two comments from the panel members on the role of communication. And I think, Jamshid, you alluded to earlier about some leaders having done that well, some probably not so well. So I'll just leave it. Jamshid, do you want to go first on the communication aspect, and then I'll go on to Harish.
This conversation on communications goes much broader. And I think, with everyone here being in a business management environment, it's a critical skill. It's not something that is relating only to a crisis, more specifically a healthcare crisis. And I think anyone who really passes out of the institute will very, very soon really need to get on top of how to really communicate effectively with the audience. So I think there's basically, just to keep it simple, three components of it. One is be transparent, because that's what people are really looking at. Because when people get the feeling that the message coming is an honest message, I think they sort of engage much better. The second thing is use appropriate channels. and use channels that basically reach out to the target audience. And the third and most important is precisely what action are you taking? So specific to the COVID situation, what I have seen locally over the past 6 months is what I really see as a kind of a best practice from global leaders. I mean, there are many other countries that have done this exceedingly well. But locally here, what I see is, I think on 7th of February, when our Prime Minister here addressed the nation on the challenge, he really did it in 3 languages. So it was a recorded message that was played on various social media channels that are used more commonly here locally. And immediately what happened was it led to a frenzy with people rushing to the supermarkets. And so you read all the stuff about toilet paper flying off the shelves and noodles not being available and stuff like that. And then he followed it up 2 days later with a follow-up message to reassure citizens that we are absolutely prepared and you really don't need to take any kind of preventive action. And he sort of detailed, including getting his ministers to the table to outline how exactly was Singapore prepared to cope with this crisis and that there wouldn't be any shortages. And miraculously, within 5 days, supermarkets were back to normal. That means people sort of had the conviction and they believed what was really being told to them. That's the first example. The second example is when I said use appropriate communication channels. So there is a WhatsApp that I'm subscribed to, and I don't know how many million people are on that WhatsApp group. Every day I get 2 messages. And the one in the afternoon is like a kind of semi-final kind of message stating, look, we've had so many cases today. And they sort of break it down and how many are new cases, how many are community cases, and so on and so forth. And it also maybe has a couple of lines outlining what exactly is the latest initiative the government has taken or any updates to the Ministry of Health's website. At midnight, if I'm still awake, I get a final message and say this is like the number of cases a day, which is also what I see in Mumbai. And every day when I read the E-Times of India paper, I'm looking at that graph and seeing how the worm is going. But the third and the most important thing, I think, in terms of taking action is as you know, I think where Singapore managed this well initially, but then ran into a little bit of a challenge was the migrant workers, where social distancing was a bit of a challenge because of the fact that they stay in dorms. And the Prime Minister went on record to say that each one of those migrant workers will be taken care of. The treatment will be free. So you're demonstrating action. Mm-hmm. He went on to sort of request people to voluntarily come forward. And of course, there's some level of healthcare coverage here. So that also kind of motivates people to come forward. So I think the government following through with taking action and even providing healthcare coverage to people who under normal circumstances would not be covered is I think is a fantastic way of again following through on that. So while we are speaking of this in the COVID context, I would say this basically applies to all aspects of our business management.
Yeah, true. Harish, any comments on channels perhaps?
Yeah, so the only thing I can mention, right, like there are algorithms to identify a fraudulent claim, right? There are certain algorithms which people are working on to identify fake news as well. So I think that's something which probably we will see getting integrated in a lot of the social media platforms, be it Facebook or anything else, right? That when you get a message, it will probably flag it that, okay, yeah, this is possibly a fake news. That's something which might be very interesting if that happens pretty well.
Brilliant. Thank you. And Ayush, you're on mute. So yeah, thank you.
So, I mean, I kind of agree with what Jamshed sir had said. I feel that, I mean, in India, the biggest problem we have faced is not fake news as much. I mean, not as much fake news as it has been incomplete information by the government. I mean, you might have had some, a circular issued by the government, like this is the testing procedure, but people are not aware as to what is to be done exactly, down to the very detail, what number to call, which lab to go to, and I mean which hospital to go to if you get any symptoms, because the hospitals you go to, they might not be having those beds. I mean the first problem which we started with. So I mean the incomplete information in terms of the government directives, because I feel those government directives have not been converted to an easily accessible format by the citizens. So I think, I mean, that is a major area which we as a government need to be improving ourselves on, as well as, I mean, in terms of the the access of the information, the channels which we're using. Because while we've used social media channels for the distribution of information, I think we should also have had more very specific information as to what kind of actions have to be taken by these people at centralized locations. Because at the end of the day, people won't be doing much with the kind of data, say for example with the number of cases, number of active cases. I mean that is something which, I mean, they'll only see and be scared of. The numbers are increasing every day. So the kind of information which they need more is to what they should be doing right now, and in case somebody around them, or what kind of precaution in case somebody around them turns positive, is showing symptoms. So I think that is something which we as government need to work on.
Couple of I think couple of very good suggestions, and a question from Krishna on that in relation to communication. I think one is, why don't suggestion that governments could collaborate better with news channels and use their existing, market and their messaging and their channels really to reach out to people. And there are some good examples of that. So there might be an area to look at. And also more around, the focus is on the COVID and the infected. What about immunity and supporting the people who are not infected?
Yeah.
What's the messaging for them? Again, that I think is subject to a whole lot of social media activity. And I suppose in that area, you would say there is probably more fake news than really in relation to COVID itself. All types of immune boosting things you can do, from magic berries to vitamin D. But there is some evidence. I think, it's really curating and finding the right channels to go for the evidence. And there is a sense at a global level that the institutions have not been as responsive in terms of communicating quickly enough with the right messaging. Even WHO, at the moment there is a concern that it's not classifying COVID as an airborne disease, and it still says the droplet infection spread, whereas now the general sense that people have is that it's airborne. And the sense is that WHO will be the last to acknowledge that it's coming, but so then you want to look at other sources which are more responsive, more quicker. Monica, your question: how are we preparing for monsoon? Will the COVID cases go up? I don't know. I mean, when is the peak considered in Maharashtra? In Kerala, my colleague was saying that it could be November, which was worrying.
Yeah. So before I comment on this, I'd like to say that ICMR in a press conference in late June, early July, said that there have been a lot of models which have been developed to predict the number of cases, but none of them has been able to get it right. So I mean, anything which we say or speculate, I mean, we should take it with a pinch of salt there. I mean, the cases would definitely be going up, but as you said, Kerala, I think, I mean, like with the kinds of things we've been hearing, late October, early November is something where we expect the peak to also.
Okay. I mean, I'm conscious of time, and I'm going to look at the last set of questions. But from each panel member, if you were to suggest one or two areas that collectively we could look at as opportunities for future from a data comms point of view, which is the topic today, what would that be? A couple of suggestions. Harish, can I start with you, being probably the more technical member of the panel?
So I think technology is fine, but I think there has to be a target. There has to be a business target given that, okay, by next March, all hospitals or all clinics should have some kind of an EMR system or something which is implemented where they can easily capture the data. It might not be so easy, but I'm saying there has to be some kind of a target deadline that, okay, yes, by this time. And I know Ayush mentioned that they were working with getting all those hospitals on their system, right? So in that way, there has to be a target that by this time, everybody should be having that data. Everybody should be able to capture that information pretty easily. So it could be 1 year, it could be 2 years, whatever the timeline is. That has to be there, because only then, because it's not like you have so many technologies, right? It's the business which is going to drive the technical aspect. It's not the other way around. It's like you have a need, only then will you buy something, right? It's not that you just want to buy it and keep it. So
Okay.
there has to be a goal, there has to be a target overall, and only then can everything else that we're talking about, right, really flow into perspective.
So that's at the government level. They have to set the policy and
Yes.
the directive to say,
Yes.
that should be the move, I think. But for our candidates, what would your top tips be? What should they learn or do differently?
In terms of candidates, you're talking about our audience, or?
Yeah, our audience. Yeah.
Sure. So from their perspective, right, I think they should get a handle of what all new things are people doing. Ayush mentioned that Nasik Hospital was working on a very good dashboard, right? It's more in terms of if I have data, right, what should I do with that data? I can just throw so many things at you, like you mentioned, right? You talked about few examples wherein you were filling the Excel sheets and you didn't know what was going to come out of it, right? What's important
Data
over here is,
visualization.
yes, data visualization. What's important is the business use case. What do I actually, once if I get all of this data, right, what should I really do with it? That's more important, because that's the selling point, not the technology. Because if you look at Facebook, right, Mark Zuckerberg did not create Facebook telling it's a .NET solution or it's something like that. He sold it in a way that it is really a solution where you can collaborate with each and everybody, right, your friends and group. That is how you're supposed to sell that solution. That's going to be the hitting the nail on the head.
So our MBA candidates could actually look at some of these use cases and learn how data has been communicated.
Yes.
Yeah, they could just try and do
tons
some
of examples, right? Predicting readmission for a patient within 30 days, finding out which patient is at a risk, possibly, right?
Yeah.
All those things you can look at. That's the value when you get the data, right? What are you going to do with it?
Okay, brilliant. That's a great. So data insights from data, and how do you visualize and communicate data? That's great.
Yes.
Jamshed, your tips.
Yeah, I think what's top of my mind is something that's a little more clinical. So I don't really know to what extent, folks at the institute can play a role. But I think the biggest informatics challenge in this space is what I call as translational bioinformatics. And by that, I mean really trying to understand the mechanism of action of this, whatever, affliction which is mutating, but also the mechanism of action of various remedies that are being used to potentially have a solve. Now, I don't know to what extent students at the institute can play a role, but I think within informatics, this is the most important thing. Because even though we may have a vaccine, even though we may have a drug, I don't think it's going to be a round peg in a round hole. This is something that's going to evolve over a period of time. And I think it will spawn an industry. It'll lead to significant career opportunities. But then again, it has that clinical aspect to it. So as maybe ultimately students of business management, directly what role can we play is a little hard to translate. But the other role, which I think is a little more pragmatic, is we spoke a little bit about wearables, and that's what I call as sensor informatics. And you have this huge population that's now going to be either monitoring themselves or lakhs of people who have recovered. And there could be, I would say, entrepreneurial opportunities here to look at something in the space of monitoring people remotely, whether it's something from a wearable, whether it's something from an app, But again, this would need a bit of an entrepreneurial kind of streak to it. So I don't think anyone can really take the bull by the horns here, but I think potentially folks can align themselves to opportunities where they can build their own contributions in the broader effort.
Brilliant, brilliant. Thank you, Jamshid. And Ayush, your thoughts?
Yeah, in terms of like, I'll just take that forward. In terms of monitoring, I mean, there's also this. So a bigger picture before that. So there's something called as ACT grants in India, which is basically 100 crore corpus, which to promote startups and innovative solutions in the field of healthcare. I mean, you have a lot of telehealth services coming out of that, a lot of monitoring services coming out of that. And I mean, one of the solutions that we are trying to pilot in a hospital in Mumbai right now is called as Cloud Physicians, which is basically capturing a hospital level data of all the patients towards to a centralized dashboard level, so that the number of trips to these COVID wards is reduced for for the doctors, making them much more safer from all of the risks. So yeah, moving forward from that, in terms of the opportunities, I mean, I feel that there's a lot, I mean, the students they can do here. One, I mean, I still feel that there's a lot of scope in terms of the kind of EMR, EHR solutions that we have to come up with. So I mean, development of those kind of solutions, because I mean, we while we do have a lot of large enterprises working towards all of these problems, there's still a lot of scope in terms of actually defining all of these in the Indian context and then trying to solve these problems. So I mean, there's a lot of scope there. Uh, Retraining of healthcare workers is something, enabling training of these people, because even in a post COVID world, like there will be a lot of scope and a lot of renewed interest and vigor, intent, from all the stakeholders. So I think, retraining of these healthcare workers, defining the roles between the administrative and the healthcare duties in a clinical setup. And I feel lastly that maybe as being students, like there's a lot of research work and consultation work which they can be doing with the governments, and governments are increasingly receptive of it. I mean, the data is publicly accessible right now. I mean, you have a lot of multiple sources. We can do a lot of analysis using that data, put out some recommendation papers, research papers, and using those we can influence a lot of policy making within the government. So I feel that, I mean, these are the few kind of areas where as students a lot of people can start working towards.
Absolutely. Thank you. I will hand over to Prema in a minute. My message really is that it's really still such a nascent area. We are, the basic blocks of data building is happening globally. There has never been, in some ways, more of a burning platform in management speak. There is a real need. There is enablers at all levels. And my dog's also barking in the background. But the real opportunity is to engage and learn from what's going on in the world, look at it in the Indian context, build programs. I think successful programs using the assets we have, even in Somaiya, for example, working with the government, working with research, working with building data. We have all the ingredients there. The secret sauce can be made there. And we have Riidl also supporting. And it's really understanding what's happening from a data science point of view, doing some background reading about all of those sometimes boring things. What's AI? What are the applications of AI? At a technical level, you can learn all of that. You can implement programs. I would have one more suggestion, which is really going back to Jamshid's earlier point around leadership and communication. It'd be good for people to look at where people have successfully communicated, and I would look at some models, including the New Zealand PM and some very effective communicators, and that authenticity, transparency, real compassion comes through very easily. Action comes through very easily. So it'd be good for all our candidates to just look through what are the ingredients, what was the secret sauce of this communication, that helps some people stand out compared to the others? And what can you personally learn from that? Those would be my thoughts, but there's a whole lot of space here. And what I would put back to Monica, Prema, and the faculty there is, let's keep the momentum. Let's get some programs going. I know Satyendra, who was there,
Yeah, he's there.
sent a message. He's still here, right?
Yeah,
there
he's
needs
there.
to be actionable programs that we should generate from this, which would be the real win-win-win. And as you've heard from Ayush, the government will be supportive. There are grants, funds, collaborative research opportunities, which we should access. Back to you, Prema.
Thank you so much. Thank you so much, Pramod. And thank you so much, all the panelists. In fact, it was extremely insightful and interesting session. And as a program coordinator and as my faculty colleagues, we have got a lot of ideas how to take our program ahead. And to tell you one interesting thing is that as it is with your suggestion, Dr. Pramod, we had introduced design thinking as the subject last year. And this year also we are going to continue, and Ayush is going to be one of the panel members. So we will be working very, very closely with the Riidl and with Ayush, and we might have more opportunities to work with the government projects and specifically related to development of apps, development of new technologies or new communication channels. That is what we discussed today. And I think the students might have taken a lot of ideas about what they can learn in the next 2 coming years, and the second year students, the last year, how it is going to be much more challenging, at the same time, much more, let's say, interesting also, along with the lot of challenges which we are facing. And we are looking forward to more such sessions. And I could see interestingly that along with these challenges of pandemic, just in 1.5 hours, we could get experiences across the countries, because we have panelists from different countries who have experiences in healthcare in different sectors. So that is a great learning experience for all of us. So I'm very, very thankful for this opportunity. Thank you so much. Anything else, Monica, you'd like to add?
Yeah, in fact, I got some very nice idea, and I thought the healthcare management students, why don't they set up some center for, bioinformatics or something like that, and we have so much student population on the campus. I think just trying to create some sort of a pilot project where, you can actually monitor the health data of these students and, maybe their immunity levels or something like that. I think that pilot project itself would give them a hands-on experience. And once you do something like this, then maybe you could look for funding to take it even ahead, maybe an app, or I don't know how, or maybe some a center where such data gets analyzed and some predictive analytics and things like that could happen. I mean, a pilot project could be set up, by the healthcare students. That would be a great hands-on learning experience for them. Because so far they've been going for, we have guest lectures, they're going for field visits. Last year they went to Bangalore and all. But I think if you have a hands-on pilot project running, that would be a great learning for these students. And they could take help from the IT professors and something like that. But even a small initiative, I think, would really make their learning more valuable and very experiential. So I think that's something which I think we can brainstorm and create something small. What is your view, Pramod and Jamshid?
Jamshid first, please.
No, I think you bring up a great point. The ability to incubate something in a closed environment without the need to worry or be under pressure for where the funding is coming from, right? Because ultimately, if you have an idea, it's going to be easier to attract the funding. So I think that's great. You touched upon the advantage of the campus and the community as being a kind of a laboratory or an incubator. I think this merits further discussion. I don't even know if you want to pull this through longer term into maybe part of the formal curriculum. I mean, maybe it's something we can speak offline.
Yeah, in fact, I think if such a center is developed, it could be, from one batch of students to the other, it could become a center where, such information is gathered and analyzed. And I mean, it would give real experiential learning to the students, and a lot of multidisciplinary ideas could be incubated from this data that we collect from the students. And what better lead than, the healthcare students, healthcare management students themselves could manage all the data that's available on the campus. Even if you just take the management school itself, we have around 2,000 students. So that data itself is very big, and then you can also extend it to their families and things like that, and I mean, within the management school itself, you'll have around 35, 40,000 data points, which is huge actually, I think, which is huge. I mean, just look at the potential that we are sitting on, and what a great learning opportunity. And then it becomes something big over the years and starts attracting funding and, a lot of innovative ideas would come out. But I think you need to take lead on that, Yeah.
We'll definitely think about it. It's a great idea.
Brilliant. Brilliant.
Yeah.
So one point I'd like to make here, right, is you could probably, have a 2-week hackathon of your own wherein all your students could form teams and, formalize their ideas. From that could be a starting point for you to start something like that.
Okay. Yeah, that's a good idea.
Yeah, absolutely.
I think you need to collaborate with the industry, like all our
Yes.
esteemed panelists, and with the IT professors in the institute, and they start developing something like that. And nothing like experiential learning, and I think what a value it will bring to us and to the students. It becomes a center which goes on, and then lot of ideas could be incubated and things like that. I mean, it's a center where you can get a lot of information. Something like that. I mean, we can give you some space in the building.
Brilliant.
Brilliant.
No, excellent. I think today's panel discussion was very insightful, but such type of panel discussions are very interesting and very useful. I would also request, why don't you have some debates, competitions and all? I mean, I know we can take this interaction to the next level slowly, Let the students also come up with some ideas and stuff,
Yeah,
You
and
make it more
students could
interactive.
debate some of the opportunities, some of the compare and contrast,
Yeah.
what's worked, what hasn't worked. But
Correct.
there are lots of case studies. I mean, this is a really rich environment to learn from.
That's right. Yeah, I think there's a huge scope for learning, and this platform, I think thanks to COVID-19, the Zoom has very activated and brought us all closer. So let's make it more useful, let's try and plan some good events and activities around this. Very interesting.
Sure.
Great.